شباب الأمة. إن شاء الله هنعمل الفيلم ريدنج سيشن بالنسبة لليورينري تراكت، وإن شاء الله يكون الموديول عجبكم و يعني يكون الشرح فيه مستوفي بإذن الله تعالى. هنبتدي الحالات والله المستعان.
Urethral structure with the bag pressure on the urethra
and the urethra
and bag pressure effect on the urinary bladder with diverticuli.
Okay, and this is a young child, as you can see, and the narrowing here is classic for the posterior urethral valve, and this valve is obstructing the flow through the urethra, and the posterior urethra is markedly dilated, and also the bladder is distended with trabeculated wall, as well as multiple diverticuli representing the sequelae of outflow tract obstruction. And this means that the posterior urethral valve is the responsible for all these manifestations. Okay.
Bilateral hernia.
Okay, did you see the history?
Metastasis.
Yeah, and this patient had an epidermoid carcinoma of the penis, and this is not the site of the inguinal canal. The inguinal canal is a little bit medial, and these represent metastatic lymph nodes. For the first look, you may imagine that these are inguinal hernias, but hernias do not contain fluid. They contain fat or even bowel loops sometimes. And these are metastatic lymph nodes from this epidermoid carcinoma.
Orchitis with multiple abscesses.
Okay, and this is actually the testis, which is considerably enlarged and is infiltrated by multiple hypoechoic lesions, and there are some vascularity in between. And if this testis is inflamed, then you may, as you said, you may got some abscesses, and abscesses are more or less well defined with characteristic margin and so on. But whenever you see infiltrations in the testis like this on ultrasound, there are a lot of differential diagnoses, and one of them is sarcoidosis, but sarcoid is not that vascular. And TB may show this vascularity, and also you may expect the possibility of metastasis or lymphoma, and this was proved by biopsy to be TB of the testis.
Following defect in the distal right ureter, enhancing the post-contrast in the axial CT.
Yeah.
This could be a transitional cell carcinoma.
Yes, right. And this is the transitional cell carcinoma of the urinary bladder. It happened to be corresponding to the entrance of the ureter into the bladder. And if you see a bolovoid mass in the urinary bladder, you may remember that I have mentioned a lot of possibilities for bladder masses, but you should consider for the first time the transitional cell carcinoma, particularly if the patient age is reason for this.
Hydrocele.
Yes, all right. And this is the testis, which is normal, and this is the scrotum, which is filled by anechoic fluid, as you can see, characteristic of hydrocele. This is MRI of the testicles showing a mass in the right testis. It is of low signal in the T1 and high signal in the T2 and contrast enhancement.
It could be according to the age, seminoma or lymphoma, or germ cell tumor if it is early, younger age.
Yes, if you do not see the age, you consider seminoma, which is the most common testicular tumor. But if the age is present, then you may consider, if the patient is young, you may consider teratoma or yolk sac tumor, but seminoma is considered the most common testicular tumor in young adults.
Pyelonephritis
Sorry?
can be pyelonephritis with fat stranding.
Yes, pyelonephritis of a specific type, which is the xanthogranulomatous type. Yes, because of the calculi, because of the enlarged kidney, because of the damage of the renal function, because of the stranding of the perinephric fat, and you may find fat within the kidney or not. This is not an essential finding. But if you see the kidney is enlarged and the function is destroyed and there are big stones within the kidney, you think of xanthogranulomatous pyelonephritis.
Seminal vesicle stone bilateral.
Yes, very good. This is bilateral seminal vesicle stone. They are too big for the seminal vesicle, but you should remember that stones can also form within the cavities located in the seminal vesicles.
Mass in the left kidney, anterior, less enhancing than the native. That is to say, it is carcinoma.
Yes, and this is renal cell carcinoma. The most common solid mass in the kidney is the renal cell carcinoma in adults.
This is for prostate cancer, elevated substrate, decrease of choline.
Yes, this is the MR spectroscopy of the prostate. And you see the citrate is elevated in the slight elevation of the choline and the creatine. What do you think?
Prostate cancer.
No?
Normal.
Yes, and this is the normal MRS of the prostate because in prostatic cancer, the citrate will go down and the choline will go up, exactly similar to N-acetyl aspartate in the brain. NAA will decrease and the choline will increase in the presence of carcinomas.
Nephrocalcinosis.
Sorry?
Nephrocalcinosis.
Nephrocalcinosis.
Emphysematous pyelonephritis.
Yes, very good. Emphysematous pyelonephritis. You know that calculi and air will produce echogenic shadows. But nephrocalcinosis, you will see the echogenicity within the renal parenchyma, but this is air within the collecting system as confirmed by the CT scan, and this is emphysematous pyelonephritis.
Fracture in the bulbous urethra.
This is the bulbous urethra, and this is usual kink between the bulbous and the benign urethra.
Structure in the prostatic urethra and membranous.
No, this is ascending urethrography, and the prostatic urethra during the ascending phase is usually collapsed, but the prostatic urethra is distended during micturition. The problem is here. What is this? What do you think?
To the adjacent structure, maybe colon or rectum
Or bladder?
or bladder.
Yeah, the only structure which is connected to the urethra is the bladder. And this is the ureter, and you see there is some kind of reflux. But this is not the actual size of the bladder. The bladder is markedly reduced in capacity with, let us say, and a very easy vesico-ureteric reflux. And this is well known in cases of
Schistosoma.
no
TB.
TB, yes. And this is well known in TB cystitis, where the bladder is markedly reduced in capacity and there is free vesico-ureteric reflux.
Benign prostatic hypertrophy.
Yes, this is prostatic hyperplasia. Classic appearance is the central zone is markedly enlarged. There are multiple bright signals representing the areas of cystic degeneration within the enlarged prostate. The peripheral zone is compressed and there is no signs of malignancy.
Fibroid calcification.
No. What is this in the anatomy?
Does it look
The
bad?
urinary bladder
Yes,
filled with
the urinary
stones.
bladder, and these are stones. And then
Stone.
there are also stones in the lower end of the left ureter. And whenever you see multiple radiopaque shadows in the region of the urinary bladder, think first of stones. Then you may go for calcification and the causes, and you may go for extravesical calcifications and the causes of these calcium. Okay.
Extraperitoneal urethral rupture.
Urethral
Extravasation
rupture,
of the
yes.
contract.
Yes, this is the urethral rupture with fracture of the pelvis and extravasation of the contrast material in the region of the posterior urethra.
Horseshoe kidney.
And you see here that the calyces are distorted and there is what looks like a tumefaction in this particular area. Do you think that this is benign or malignant?
The cyst.
Yes, and here the differentiation between benign and malignant lesion between cyst and renal cell carcinoma is the appearance of the calyces. If the calyces are only stretched and displayed, you think of a cyst. If the calyces are amputated or irregularly eroded, then you think of a malignancy. And this is horseshoe kidney with a simple renal cyst on the right side.
Cystocele.
Yes, and this is herniation of the bladder in the scrotum, what's known as cystocele. This is right. and this is the cause of the patient complaint.
Renal vein thrombosis.
Okay, very good. There is a big filling defect in the renal vein, the left renal vein, of course. This is the IVC, which is good, and there is a thrombus in the left renal vein. This is the scrotum.
Hematoma.
Yes,
Hematoma.
hematocele. And this is scrotal hematoma, the only collection which contains internal septation. And this differentiates the hematoma, and even without the history, from the simple hydrocele or biocele or others. Yes.
Calcification seen, mass calcification or lesion calcification in the right mitochondrium
Yes.
with nephrogram on the left kidney.
Okay. This is
But it's
nephrogram,
just
and this is calcium without nephrogram.
that I think there is calcified mice on the right and there is obstruction on the left. This is called the nephrogram.
Calcified what?
Lesion in the left and the right kidney.
What do you think of this lesion?
Body kidney?
Yes, and this is body
TB.
kidney with TB. And I have emphasized this fact many times in the lectures. Whenever you see calcium in the kidney, which is most likely non-functioning, and you think of TB, and also if you see calcium in the ureter and you think of TB, but this kidney may be normal, and this is the early phase of the intravenous urography. But calcium in the region of the kidney, which is most likely non-functioning, is highly suggestive of renal tuberculosis.
Urethral diverticulum.
Yes, and this is female urethra with a diverticulum, which of course is uncommon, but you can see it sometimes in the clinical practice.
Also diverticulum in the urethra?
Okay, it
Or
looks
syringocele
yes,
of the urethra?
and this is syringocele.
Ejaculatory.
Yes, and this is syringocele in the urethra, which is known as the Cooper duct cyst, and you can see that the syringocele is almost parallel to the lumen of the urethra and is connected to the Cooper duct, which leads to the Cooper gland, as you know. But whenever you see a cystic lesion within the course of the urethra in the male, of course, then you think of a syringocele until proved otherwise.
Diverticulum of the urinary bladder?
Yes, it is written below the image that this is the bladder diverticulum. And one of the good policies is to look inside the diverticulum for stones or for carcinoma, for example, but this is not.
Urethritis, cystic urethritis.
No, and the answer is
And
here. Yes, that you have multiple
transitional cell carcinoma.
yes, and these are lesions, and this is one of the lesions that is relatively big in the lower part of the ureter. Multiple filling defects that they are sizable compared to the ureteritis cystica. And you know that transitional cell carcinoma can be multifocal. It can be seen in the collecting system in the ureter as well as commonly in the urinary bladder.
Fistula,
Fistula between,
this is bladder and bowel.
yes, and yeah, the diagnosis is
Crohn's season.
Diverticulitis.
we don't know actually. We do not have a good segment of the colon to judge what is the pathology, but all what we have here is the connection between the bladder and the colon, which is known as the vesicorectal fistula or colovesical fistula.
Papillary necrosis.
Yes, and this is right. Renal papillary necrosis. And you can see the contrast material within the apex of the pyramid, which is one of the criteria of papillary necrosis. And you know that this lesion is intimately related to non-steroidal anti-inflammatory drugs, is also seen in sickle cell anemia, in infections like TB, and in diabetics. And the answer is here, and this is a connection between the rectum and the bladder, and this is a rectovesical fistula in a young child, as you know.
Pyelonephritis.
Acute, acute pyelonephritis. This patient is diabetic with pain and hematuria, and you see that the kidney is enlarged, the excretory power is poor, and there is a striated nephrogram, and you may see some stranding of the perinephric fat. All these are the criteria of acute pyelonephritis.
Hydrourethra.
Reflux.
Yes, reflux. And you see, this is ascending erythrogram. This is the normal capacity of the bladder. And there is a vesico-ureteric reflux on the right side.
Mass on the left aspect of the urinary bladder. Mass
Yes,
could
this
be
is
transitional tear.
the mass or this one.
The hypointense. The
Yes,
hypodense, sorry.
hypodense lesion. This is urine in the urinary bladder, as this is with contrast. And you got a big filling defect or an area which is not filled by contrast with a soft tissue mass in the bladder, diagnostic of,
Transitional
yes,
carcinoma.
urothelial carcinoma.
I think this is fistula again.
Yeah, between.
I think this is uterus.
Between.
Not sure. Is it between the bladder and uterus?
No, this is the vagina, and
Okay.
this is the bladder, and this is the vagina. And it's very rare to get a fistula between the bladder and the uterus, but it is an easy way to get this type of fistula, which is known as vaginal fistula.
bilateral reflux.
Yes.
Grade 5.
And this is bilateral grade 5 psychoureteric reflux. You got severe dilatation and tortuosity of the ureters with distension of the pelvic ileal system. And you know, if you do not see this catheter in the urinary bladder, you cannot differentiate between vesiculoreteric reflux high grade and congenital megacystis megaureter syndrome. Sometimes you may have difficulties between this, but if the examination is ascending cystography, you think of reflux. If not, you think of megacystis megaureter.
Left side kidney is not visible.
Yes, absent left kidney. And if the kidney is small, sometimes you are not able to see it in the urography, but you can see it in the CT scan or ultrasound. If the kidney is small and you do not see here, these are the possibilities: obstructed, ischemic, or infected kidney. But if it is absent, you will not detect any renal tissue by any of the imaging modalities.
Xenobacteria.
Yes, ectopic malrotated left kidney, and this kidney sometimes is superimposed on the sacral ala, and you cannot see actually, and is frequently seen in the exams.
Maybe left side ureterocele?
It is left-sided urethrocoel, and the cobra head appearance is quite evident in this evacuation phase. And you can also sometimes see the lesion here, and is not quite evident in this early filling phase.
Maybe left, right renal.
Okay, the TB is a good possibility, and also you should consider the possibility of densogranulomatous pyelonephritis. TB of the kidney will shrink, but densogranulomatous pyelonephritis, the kidney is large, and it contains multiple sizable calculi as well as poor function.
Duplicated ureter.
Yes, this is
Drop,
duplex
drop water lily.
drop flower appearance.
Water lily.
Drop lily.
Or this is water lily. It's drop lily, I think. You know that there is a duplication of the collecting system, and the upper moiety is obstructed, and it will compress the lower moiety, resulting in this classic appearance. So this is duplex left kidney with obstructed upper moiety.
Striated both kidney, according to the possibility or history. And there is many differential diagnoses on the tip list: acute pyelonephritis, hypotension,
Hypotension.
also called striated. But here I think it is acute pyelonephritis.
The most common cause for striation of the kidney, which is still functioning, and you can see is the acute pyelonephritis, which can be unilateral or bilateral.
This is congenital anomaly, megacystic
Yes,
megaureters.
this is what I have mentioned before, that the ureters are huge, and even here you do not see so much dilatation in the collecting system apart from the renal pelvis, and you also see that the bladder is huge. But in cases of zygoreteric reflux, and you got also ballooning of the calyces.
Maybe of the left side of kidney.
Yes, you should remember this every now and then. Whenever you see calcium, and the kidney is small and is not functioning, and you think of renal tuberculosis.
Bilateral urethrostomy.
Yes, and this is bilateral erythrocoel cobra head, larger on the right side, relatively smaller on the left side.
Bilateral non-rotation of both kidneys.
Yes, and this
Horseshoe kidney.
horseshoe kidney with mal-rotated collecting system and a small renal cyst, which is not evident in the excretory urography, but can easily appreciated in the CT scan.
The psychoelectric reflex.
Yes, what is the cause? And then this is,
Posterior urethral
yes, and
valve.
almost similar to the first case where you see that the posterior urethra is markedly distended, the anterior urethra is good, and there is what looks like a constriction here corresponds to the site of the valve. Then you got bladder outlet obstruction with trabeculated outline and huge bilateral zygouriteric reflux.
Urinary bladder mass with the effect of hydronephrosis on the right kidney. That is a transitional cell carcinoma.
Yes, and this is invasive urothelial cancer that affects the right side of the posterior aspect of the renal bladder and has extended outside the bladder to infiltrate the ureteric orifice, and there are some stranding of the fat planes, and also you can see that the collecting system is dilated secondary to ureteric obstruction.
Macrolithiasis.
Yes, and this is
And the
testicular microlithiasis. And there are only two lesions which can produce these echogenic structures within the testicle, and these are the testicular lipomatosis and the microlithiasis, as you know.
Retroperitoneal fibrosis.
Yes, and this is retroperitoneal fibrosis because of the medial deviation of both ureters and the back pressure effect on both kidneys. And this is the famous appearance and is usually seen in the era of IVB.
Absent left kidney with a compensating
Yes.
enlargement of the right kidney.
The left kidney is absent, but there is discrepancy
leg.
between the size of the renal valves and the ureter. And this means that there is some sort of obstruction here, which means that there is pelviureteric junction obstruction as well. Then you got absent left kidney and pelviureteric junction obstruction of the right kidney.
Wilms tumor of the left kidney.
Wilms tumor or it's known also as nephroblastoma. This is a pediatric patient, 3 years old, and you got a solid mass in the left kidney, and the most common solid mass in the kidney in the pediatric age is nephroblastoma or Wilms tumor.
POJ of the right kidney.
Yes, and this is advanced degree of pelvic junction obstruction with ballooning of the renal pelvis as well as ballooning of the calyces.
Von Hippel-Lindau.
Yes, very good. And this is von Hippel-Lindau syndrome because of multiple cysts in the kidneys, mass in the right kidney, and cysts of the pancreas. It is one of the good policies is when you see extensive cystic lesions in the pancreas, you think of von Hippel-Lindau and you look for other stigmata in the kidney, in the liver, or elsewhere, because simple cysts of the pancreas are not common. And if you see multiple cysts in the pancreas, in any cysts elsewhere, as well as masses and so on, you think of von Hippel-Lindau syndrome. The time is going up, but don't leave. I will, if the software is not working, I will rejoin. Okay, then
Ureteric diaphragm on the proximal distal part of the left ureter.
ureteric what?
Diaphragm or stricture on the distal part.
Okay, and you see that the renal pelvis is huge, the ureter is tortuous and dilated, and of course this is not a stricture because it is of a good caliber in here, and if it is a stricture it will be thread-like, and in order to result in this huge dilatation of the proximal part of the ureter and pelvic cell system, and this is of course a high grade reflux on the left side, and less grade or grade 3. This is grade 3 on the right side, and this is grade 5 on the left side.
Bilateral, divertical.
No.
Maybe fistula.
Yes, between. Okay, then I will come back to you. Let us يا دكتور شريف. بيقول لك الهوست has disabled the participant.
جرب تاني كده ساعتك.
نجرب تاني سيادتك كده، انتوا شايفين؟ ها؟ كده شايفين الشاشة؟
شايفينها.
طيب نكمل.
اتفضل.
يلا. And the answer was a fistula between the urinary bladder and the vagina. And you see, this is the urinary bladder on the on the back, or let us say so. And this is the distended vagina with contrast material. And this is, of course, is not the urinary bladder.
Xanthogranulomatous
Yes,
pyelonephritis.
this is xanthogranulomatous pyelonephritis, typical appearance, big kidney with big stones, poor function, and there may be some fat. Fat is not essential, but if it is present, it will support the diagnosis.
Focal lesion in the central zone or central gland on the left side.
Prostatic
Suspected
cancer.
This one,
cancer.
this one,
No, on the left side,
this one.
which is high, which is enhanced on the post contrast.
Yes.
Exactly.
As in the T2, this lesion is present in the peripheral zone. This is the central zone, and this is the peripheral zone, which is of bright signal in the T2 weighted image. And the lesion is of black signal, and this is ADC, that is restricted diffusion and homogeneous post-contrast enhancement, diagnostic of.
Prostate cancer.
Yes, and these are the typical criteria of prostatic cancer. It shows low signal in the T2 weighted image within the high signal of the peripheral zone. On diffusion, it will show restricted diffusion, bright in the diffusion weighted image, and dark in the ADC with evident contrast enhancement after contrast injection.
Ureteric stone cause atrophy of the right kidney.
Yes, very good. This is known as post-obstructive renal atrophy. This stone is present long time and has resulted in atrophic changes of the kidney, which is also harboring another stone.
Hydrocele of the
Yes, this is hydrocele
left side.
and
Scrotal
scrotal edema, yes, and this is a typical appearance of scrotal edema, which is fontaine-like, and you see these appearances if they are by the Doppler exam, you will got some high vascularity here. This is typical of scrotal edema, and you see also a hydrocele.
Bilateral reflex.
No, this is urography, intravenous urography.
ureteric mass
Where she meant
filling defect
on the right or on the left?
on the left side, mid part of the left ureter. Exactly. Exactly. Transitional cell carcinoma.
No, and you should notice that the ureters are medially deviated, lying all over the spine, and there is some back pressure effect on one of the kidneys or even both, and this is
Peritoneal fibrosis.
yes, and this is retroperitoneal fibrosis. Okay.
Tunica albugen cyst.
Very good. And this is tunica albuginea cyst, and this is the cyst which is located peripherally outside or even on the margin of the testis, which is not similar to that present within the testicle itself.
Tuberculosis of left side kidney.
this is spot diagnosis of renal TB. Dense calcification in the region of the kidney. These are not, of course, calculi. The kidney is small in size. The right kidney, there is a stent of the ureter, and this is TB of the kidney.
Invasion of the urinary bladder with posterior lateral aspect under it, aspect mass.
This patient had a recurrent rectal carcinoma, and this is the rectal carcinoma. Then what do you think of this?
This is small, like invasion.
Metastasis, and this is seminal vesicle metastasis, because the tumor is not in close in contact with the seminal vesicle. Then this is metastatic deposit, not a direct invasion.
Seal of the urethra.
Yes, that is syringocele, similar to the previous one. And you see the lesion is tubular, lying parallel to the course of the urethra, connected to the fine duct here, and this is the Cooper's gland duct, and this is syringocele. The answer is here, and this is urethritis, because you see irregularity of the urethra with filling of the urethral glands and speculated appearance. This is a characteristic of urethritis of whatever etiology. What do you think of this? This is the testis, and this is the scrotum with some fluid, and there are multiple shadows here. What do you think?
Fat, lipoma,
No, these
lipomatosis.
are stones. And you see the acoustic shadowing. Then what are the name of these stones or calcified shadows? Do you remember scrotolith? I have mentioned in the lecture. You remember it? No?
Yes, yes.
Yes. Okay. They can be single or maybe multiple, and they have the characters of calculi with echogenic appearance and the acoustic shadowing, posterior acoustic shadowing.
Polycystic kidney disease.
Yes, this is polycystic kidney disease. There are some cysts also in the apparent part of the liver as well.
RCC,
Are
renal cell carcinoma.
Yes, and this is renal cell carcinoma with calcium. And you remember that I have mentioned that renal cell carcinoma, bronchogenic carcinoma, hepatocellular carcinoma can show matrix calcification.
Seminal vesicle invasion.
Why?
Loss of the hyper intensity signal, the right one.
Invasion by
Prostatic carcinoma.
And this is prostatic cancer. You see this low signal lesion in the right side of the prostate, which is inseparable from the seminal vesicle. And the seminal vesicle is dark, similar to the tumor, with loss of the normal bright signal of the fluid inside the seminal vesicle.
renal abscess.
Yes, very good. And this is renal abscess, marginally enhanced lesion with stranding of the perinephric fat. These are two different cases of cyst in the epididymis.
One is epidermoid, one is spermatocyst.
Spermatocele. Yes, both epididymal cyst and spermatocele are difficult to be distinguished from each other, but if you can see some debris and maybe fluid level inside the cyst itself, you may think of spermatocele. But if you see that the fluid is clear, it may be an epididymal cyst or maybe a spermatocele.
Hydrocele with epidermoid of the testis.
No, and this is not an epidermoid, and I have advised you that if you see a mass in the testicle, consider seminoma, which is the most common. Then this lesion is of low signal in the T1, high signal in the T2, and also of high signal here, and some evident contrast enhancement with big hydrocele, and this is seminoma of the testis. The epidermoid cyst has a specific appearance, and maybe there is a case here. And what do you think of this?
Can be prostate cancer.
Yes, and this is prostatic cancer to the left or to the right?
Left side.
To the left. And here, this is the low signal lesion, which is located in the peripheral zone on the left side, diagnostic of prostatic cancer.
Bilateral microlithiasis.
Yes, but the testicles are not normal.
Yeah, develops seminoma.
Yeah, bilateral. And you got a mass here and another mass here. And these are in, you know, the relation between seminoma and microlithiasis. They can both exist in the same testicle. And microlithiasis, it can be bilateral. Also, seminoma can be bilateral.
Emphysematous
Yes,
pyelonephritis.
emphysematous pyelonephritis with classic air within the renal parenchyma.
Intratesticular varicocele.
Very good. Intratesticular varicocele is an abnormally dilated veins within the substance of the testicle itself. And most commonly, the varicocele is present in the Bambiniform plexus of veins draining the testis, but sometimes this varicocele can be inside the testicle itself. And you know the relation between varicocele and the Valsalva maneuver, where the varicocele will be distended on this maneuver.
Degenerative cyst of the central bladder.
This is the prostate, not the bladder.
Prostate, sorry.
Yes, and
Prostate.
this is the central zone, which is markedly enlarged, being the seat of multiple areas of bright signal, diagnostic of benign prostatic hyperplasia. The central zone normally is relatively black, and it is of homogeneous signal intensity, do not contain these areas. But whenever you see this, and you think of benign prostatic hyperplasia.
Rhabdomyosarcoma.
Rhabdomyosarcoma, you need the age of the patient because rhabdomyosarcoma are usually seen in young patients, but this is a malignant lesion. What do you think?
Sarcoma invasive of the bladder.
Let us say it is a malignant lesion, but if it is it in the rectum or in the prostate or in the bladder?
I think it's in the prostate and invasive both.
Yes, you think that it is in the prostatic in the prostatic area,
Epicenter in the prostate and it's invasive interior
invasion
to the prostate.
of the
Both.
bladder and the rectum. You
But
think, but
yeah,
I don't remember, but I think that I mentioned in the lecture that the prostatic cancer has difficulties to invade the rectum because of the dense and
fascia.
yes, and but the rectal cancer is able to invade the prostate, and also you see that the main bulk of the lesion is located posteriorly in the area of the rectum. But you need, of course, the clinical data. And if you say that this is just a malignant lesion invading the rectal area, the prostatic area, and the bladder, this will be quite enough for the diagnosis. This patient had a previous history of prostatic biopsy, and the lesion is in the seminal vesicles. What do you think? Anyone is here? What?
Inflammation, seminal vesicle inflammation,
No, the
bilateral.
seminal vesicles are bright in the T1, meaning that they contain hemorrhage. And
Blood.
yes, and this is post biopsy hemorrhage in the seminal vesicles. And the hemorrhage can be of dark signal, of course, in the T2 weighted image, meaning that it is in the subacute phase.
Epididymitis.
Epididymoorchitis, because the
Epididymoorchitis.
epididymis is affected and the testis is also affected. And you should have the color Doppler study of the testis to be able to diagnose this disease. Otherwise, you should have the positive clinical history of inflammation like testicular pain and edema and swelling. And this is inflammation of the epididymis and the testicle, which is epididymoorchitis, which is more common than epididymitis or orchitis as a single entity.
Multiple lymphadenopathy noted in the left inguinal area.
Yes, these are lymph nodes. And this?
This is a prostate.
Okay, the diagnosis is?
I think lymphoma of the prostate.
But what?
Prostatitis inflammation.
Okay, then we have three possibilities: prostatic cancer, prostatic lymphoma, and prostatitis with inflammatory nodes. You know that inflammatory nodes are not solid like this. They should contain some central areas of breakdown, and the periprostatic fat should be stranded, and also the fat around the lymph nodes. Then prostatitis is not in the differential diagnosis. Then we came to the possibility of carcinoma and the lymphoma. What do you think? Carcinoma is more common or lymphoma?
Carcinoma.
Of course, then you should diagnose this as prostatic cancer with metastatic lymphadenopathy until proved otherwise. as carcinoma is much more common than lymphoma in the prostate.
Intraperitoneal rupture of the urinary bladder.
The bladder is intact. And you see, this is the urinary bladder and the catheter inside the urinary bladder. The problem is in the urethra. The urethra is ruptured and the bladder is floating high up, which is known as pie in the sky. You remember this term? Pie in the sky?
Yeah.
Yes, and this is rupture of the urethra with the bladder like the pie in the sky.
There is mass in the urinary bladder.
Yes.
I think transitional cell carcinoma.
Yes, involving the distal part of the ureter with dilatation of the ureter. Okay, the patient age is 19 years old. No problem, of course, no problem according this age. And you know the intimate relation between bladder cancer and cigarette smoking. And maybe some of the young patients are smoking since early in life, and they may got bladder cancer. But we should diagnose this as bladder cancer until proved otherwise. The cystoscopic biopsy showed inflammatory myofibroblastic tumor of the urinary bladder that I have mentioned in the lecture, but you cannot predict the nature of this mass without the histologic proof.
Left-sided kidney is not visible.
No, it is visible. I said that sometimes the kidney is superimposed on the sacral area, and you can also easily see the ureter of the left kidney. Then whenever you see this ureter, you should look carefully here in this area for the collecting system. And this is ectopic pelvic kidney. شكرا جزيلا وإن شاء الله موفقين بإذن الله تعالى ونتمنى لكم موديول سعيد بإذن الله. هل في
شكرا
عندكم
دكتور.
أي أسئلة أو طلبات؟
جزاك الله خير.
شكرا حضرتك. نراكم على خير إن شاء الله. السلام عليكم ورحمة الله.